Okay, good afternoon. My name is Dianna Smith, and I am both a pediatric neurologist and also a patient. Thank you very much for the opportunity to share my story with you today and kind of kick things off for this event. You would think that my own diagnostic experience would be a little bit different than most people, since I was a medical student at the time that I was diagnosed, and I had access to resources that other patients did not. But it took me 5 years to be diagnosed correctly and to get answers for my own condition. So in many ways, my experience wasn't different from a typical patient's. I first noticed that I had a lump in my neck during the first year of medical school. I visited my student health center shortly after I discovered the lump, and the clinical staff there told me that it was just a swollen lymph node, prescribed me antibiotics, and then sent me on my way. That scene would play out repeatedly over the course of the next 5 years. I went back to student health again and again over the course of my time in medical school. Each time they told me the same thing: don't worry about it, it's probably nothing, it will go away on its own. And I remember at one point I started to convince myself of this. I started to think, if it was serious, it probably would have killed me by now. But by my 4th year of medical school, the lump in my neck had gotten harder and bigger. It was firm, it was fixed, and had all of the signs that they teach you about in medical school are concerning for cancer. I knew it was bad, but still, I said nothing. I started a surgical ENT rotation with this lump on my mind every day. And informally, at the end of the rotation, I asked my attending to take a look. He told me the same thing that I'd heard at student health. It was probably just a lymph node, probably nothing, and I went on my way. I completed medical school, moved to a residency program in a new city, and got a new primary physician. And I had hoped that at some point, someone would listen to me about this lump. But at that time, it was about the size of a walnut. It was hard, fixed, and felt attached to several lymph nodes in my neck. I had occasional dizzy spells. I felt a constant nagging pain. So I told my physician about this. Still, it took her a year before I convinced her to get a CT scan. The scan confirmed that it was a carotid body paraganglioma, which is a rare tumor. I met with an ENT specialist at the time and then a vascular surgeon. They thought that it was benign, as those tumors usually are, and said that I had nothing to worry about. I underwent surgery not long after this to have the tumor removed, and the surgery went well, but as I was getting the stitches out a week later, my surgeon told me that the tumor was malignant and I would need to undergo a cancer workup. He had said that it had spread to metastasize to nearby lymph nodes by that point, and I would also need a surgery to have the tissue in my neck removed. There was a complication during that surgery, the one that I had to remove the cancerous tissue in my neck. One of the arteries had been injured during the surgery, but the team was able to keep the bleeding under control, and everyone thought that everything was fine. When I first woke up a few hours later, everything did seem like it was okay, but 12 hours later, I started to have neurological changes. I couldn't move my entire left side, I couldn't swallow, and those were the first signs that I had had a stroke. Even now, 7 years later, I still feel the effects of my delayed diagnosis every day. Luckily, I am cancer-free at this point, and I've recovered most of the function in my left leg. However, my left arm is still weak and has limited sensory function. I still have trouble using my left hand, and I still have trouble swallowing. Looking back, I just wish that someone had listened to me. I knew that something was wrong. If student health had taken me seriously in those early days when my mass was smaller, I have to wonder if I would have needed the second surgery, if the cancer would have had time to metastasize to those lymph nodes, if I would have had the stroke, and if I would have had other complications. I don't blame my physicians for my conditions or even for the complications that occurred after my surgery. My form of cancer is extremely rare, and it's much more likely for an otherwise healthy young woman to be diagnosed with a benign condition. But I still just wish that they had listened to me. My illness has affected the way that I practice as a physician. I find myself on the patient side now more than ever before. I try to make sure to listen to my patients and work with them to treat their conditions. I'm a pediatric neurologist, so I see a lot of complicated cases. But despite my clinical expertise, I don't downplay the value of the lived experience. I also know when to call for help if I need it. I'm not the one who's going to dismiss a patient's concerns. I completed a training program with the Association of University Centers on Disability during my last year of neurology training, and now I advocate for patients with disabilities in and out of my clinic. I share my own story as a way to reach out to other disabled people. And one of my own attending physicians shared his stroke story with me shortly after my own stroke, and hearing that story made me feel like I wasn't alone for the first time. I just hope to share my own story and foster that same kind of connectedness. So today, I'm sharing my story with all of you with the hopes that someone who's going through something like this doesn't feel so alone. Inaccurate and delayed diagnoses affect both patients and clinicians every day, and it's going to take all of us working together to improve diagnosis.
Good afternoon. Welcome, everyone, and thank you for joining us today, including the several hundred from across the country who are joining us via webcast. Thank you, Dianna, for sharing your very moving story. I wish that I could say your experience was unique, that it's highly unlikely to happen again to you or to others. Unfortunately, I cannot. Chances are every one of us gathered today, whether in person here on Capitol Hill or following along virtually, will receive an inaccurate or delayed diagnosis at some point in their lifetime. It's happened to me. It's likely happened to you, or if not now, likely in the future. Many of us will be lucky enough to eventually be diagnosed correctly, receive the appropriate treatment, and regain our health completely. Some, like Dr. Sejas, will have longer-term repercussions that linger with them throughout their lives. For others, however, the consequences are far greater. Inaccurate and delayed diagnoses can lead to serious injury, permanent disability, or even death, and this happens all too frequently. As many as 12 million adults receive an inaccurate or delayed diagnosis annually here in the U.S. alone. They carry a staggering price tag, not only in terms of the lives they negatively impact, but also in the more than $100 billion that they cost our healthcare system annually. Since its establishment in 2011, the Society to Improve Diagnosis in Medicine has been the only organization of its kind focused solely on addressing inaccurate and delayed diagnosis. We remain steadfast in our commitment to reduce the toll, both in lives and in dollars. But to do so, we must have proven solutions. This is where Dr. David NewmanToker comes in. His new research, appearing online today in the peer-reviewed journal Diagnosis, looks at medical malpractice claims and confirms some of what we previously thought. Diagnostic errors are the most common, most catastrophic, and most costly of serious medical errors. But importantly, his research also sheds new light on the disease categories and care settings in which many of these inaccurate or delayed diagnoses are happening. Please allow me to introduce Dr. David NewmanToker, Professor of Neurology and Director of the Johns Hopkins Armstrong Institute for Patient Safety and Quality's Center for Diagnostic Excellence, to talk more about his team's research findings. David?
Thanks so much, Paul. And thank you for everyone who's here today with us in this packed room, and for everyone on the webcast who's here with us remotely. This is a really important event, and I'm glad that you could all be here with us today. I want to thank Dianna for sharing her very difficult and traumatic story with us. It's stories like hers that I saw, unfortunately, over and over and over again during my training as a physician that motivated me to come do this work and to devote my career to tackling this problem. And I hope that we can all work together to do that going forward. The work that we did, and I'm about to describe to you, is a first part of a three-part study that is ultimately aimed at measuring the total annual burden of harms from diagnostic errors in the United States of America. And in this first stage, really what we were focused on doing was identifying the diseases that are most often responsible for serious patient harms as a result of diagnostic errors. And I'm going to provide you some insights here. What I hope you take away from this is not just the incredible sort of eye-popping information about the severity of this problem, but also that we've started to gain insights into how to move the ball forward to fix this problem, but only if we work together and we commit seriously to making a difference in this area. So what we did in this study was we looked at a very large national medical malpractice claims database through the CRICO comparative benchmarking system, and we looked at over 11,000 diagnostic error claims. We focused on the 7,000 plus that were associated with serious harms. And when I say serious harms, I mean permanent disability or death, equivalent in severity to losing a limb or an eye or worse. So these are very high severity claims. And what we found, much of this confirming what we have previously seen in the National Practitioner Data Bank, et cetera, is that diagnostic errors are the most common, most catastrophic, and most costly of medical errors. They represent 34% of all the medical errors that cause serious harms, and so that's the #1 cause of serious harms. They cause harm when they occur. 64% of the time, they lead to death or permanent disability. That's the most severe, most catastrophic. And they're responsible for 28% of all payouts from malpractice claims in these data, similar in the National Practitioner Data Bank from a study that we did several years ago, again, ranked #1, with a median payout per high-severity claim of $766,000. There were total claim payouts in the CRICO database of $2.65 billion over 10 years, but that's really just the tip of the iceberg. Because not only is that only about a third of the total claims in the US, so it's closer to $10 billion a year, roughly, over that 10-year period, but it's much bigger than that. So malpractice claims represent about 1% of all the serious harms that are out there. So for every one malpractice case, there are another 99 where the same kind of harm comes into play, but it doesn't lead to a malpractice claims case. And we've estimated in a study that we published in abstract form last November at the Diagnostic Error in Medicine meeting that the total societal impact of this problem is well over $100 billion a year. That's billion with a B. And it may total up even closer to the trillion mark. So we know that this is a major problem, both at an individual personal level, as Dianna articulated to you, but also at a societal level, and something that we really have to take action towards fixing. This study breaks new ground in this way. So not only did we confirm the severity of the problem, we started to dial down into where these serious events are happening. And I'll focus first on the issue of what kinds of diseases we're talking about. So 3 major categories of disease: vascular events like stroke and heart attack, infections like sepsis, pneumonia, and meningitis, and cancer cases like lung cancer, colorectal cancer, et cetera. These sorts of diseases are responsible for 3/4 of all the permanent deaths and disabilities, and it's split about evenly, 50-50 between death and disability. More importantly, I think, in some measure, is that within these categories, there are the 5 top diseases that I pointed out to you there on the screen. These 5 diseases in each category together account for about 50% of all the serious harms in the claims data. And what that suggests to us is that although diagnostic errors happen everywhere, across all of medicine, in every discipline, with every disease, that we might be able to take a big chunk out of this problem and save a lot of lives and prevent a lot of disability if we focused some energy on tackling these problems. It at least gives us a starting place and a roadmap for how to move the ball forward in this regard. So I think that's a critically important insight that really wasn't known prior to this study's publication today. The other thing that we learned is that the distribution of where these errors occur isn't equal. So we know that the majority of diagnostic errors happen in outpatient clinics, in large part because there are many more outpatient visits than there are visits to the emergency department or hospital. We know that the emergency department is a particularly high-risk site because patients go there when they're sick and because the level of uncertainty and illness severity is high. And inpatient care is quite complex. So they happen in all areas of medicine, but what we can see from this diagram is that in outpatient clinics, disproportionately we see harms from cancer cases that are missed, where this longitudinal evolution of the problem is a major factor. Whereas in inpatient and emergency department settings, disproportionately vascular events and infections are to blame. That gives us some insights as to how we might approach this problem. In adult clinics, maybe we should focus on tackling the top 5 cancers. In childhood clinics, where we know that we analyzed the subgroup of pediatric events, infections were disproportionately to blame, let's focus on the top 5 infections. In the emergency department and inpatient settings, tackle the top 5 vascular events and the top 5 infectious causes. That's a roadmap for how to move forward. But in order to do that, we have to take this issue seriously. Right now, research funding is inadequate. The agencies that are devoted to this issue, the Agency for Healthcare Research and Quality and others, are doing yeoman's work with the money that they have to be able to get this work done, but it's very limited. The total amount of federal spending on this issue each year is less than $10 million a year based on our estimates, and that's less than we spend each year on smallpox research, a disease that was eradicated over a half a century ago in the United States. So we are off by several orders of magnitude. So what I'd like everyone to do is to heed the National Academy of Medicine's message from 2015. The delivery of healthcare has proceeded for decades with its blind spot, diagnostic errors. Most people will experience at least one diagnostic error in their lifetime, sometimes with devastating consequences. And this is the most important thing. Improving the diagnostic process is not only possible, but represents a moral, professional, and public health imperative. That is strong language, and it is absolutely accurate. And we need to own that. Together, we need to own that. So what should we take away? Clearly, diagnostic errors are the most common, most catastrophic, and most costly medical errors, both for society and for individual patients. 2, a place to start is with the big 3, cancers, infections, and vascular events. Together, these account for about 75% of the serious harms from diagnostic error. And 3, the investment in research to tackle the problem lags its public health burden by a wide margin, several orders of magnitude. We need to treat this, in the words of the National Academy, as a public health imperative. And I thank you for your attention.
Thank you, David. While this research provides new insights into specific incidences of misdiagnosis, it's vitally important we remember that inaccurate or delayed diagnosis happens everywhere, as David said, across all disease categories and with all clinical care settings. For too long, the problem of inaccurate and delayed diagnoses was not given the attention it deserved. As such, it's largely flown under the radar in our quality and safety programs. We've only recently begun to more fully understand the scope and scale of this major public health problem, and it's becoming increasingly clear that we must make identifying and testing possible solutions to help us prevent them an urgent national research priority. We're making important progress on this front because Congress has taken notice. We want to thank the members of Congress who have taken a leadership role in helping to increase federal funding for critically needed research, in particular Senators Schumer, Blunt, and Van Hollen in the Senate, and Congressman Lujan and Billy Rakes in the House. We thank them and others for their leadership and willingness to roll up their sleeves and tackle this most pressing issue. This year's House Appropriations Bill proposes to increase dedicated funding for diagnostic quality and safety research to, quote, not less than $4 million. That's up from $2 million last year. It's a small step, but in the right direction. The federal investment in research remains, though, as David said, trivially small in relation to the public burden. That's why we urge Congress to commit to research funding levels proportionate to the societal costs in both human lives and in dollars. The Federal Agency for Healthcare Research and Quality, or AHRQ, has recently prioritized reducing harm from diagnostic error as one of 3 essential areas to improve patient care. The agency declared inaccurate or delayed diagnoses an urgent challenge and set a goal of reducing the more than 12 million diagnostic errors that take place each year by 10%. And in response to a request from Congress, AHRQ is convening a federal interagency work group on diagnostic safety and quality to raise awareness of this issue across federal health agencies, the Department of Defense, Veterans Affairs, National Institute of Health, Centers for Disease Control and Prevention, Centers for Medicare and Medicaid Services, even the National Library of Medicine, whose missions all include small pieces of the diagnostic puzzle. This is encouraging, and progress is possible, but improving diagnosis will take all of us. The federal government certainly, researchers like David, the extended healthcare community, and others. Everyone has a role to play, including health systems, physicians, nurses, radiologists, laboratory scientists, patient safety and quality improvement efforts, and patients. We must not forget patients and their caregivers. They are an integral member of the team. To this end, the Society to Improve Diagnosis in Medicine has convened the Coalition to Improve Diagnosis, a coalition of more than 50 organizations representing leading healthcare and patient advocacy organizations, several of which are with us today in person and online. Together last fall, we launched ACT for Better Diagnosis, where ACT, A-C-T, is an acronym for Accurate, Communicated, and Timely, the 3 key elements of the National Academy's definition. And it illustrates our shared commitment to taking action, sharing best practices, and working collaboratively to improve diagnostic quality and safety. As a member of the coalition and as someone who can bring today's research findings to life in the way that only firsthand experience can, I'd like to introduce Tom Heyman, President and Executive Director of the Sepsis Alliance. Tom?
Thank you, Paul, and thank you all for being here today. I'm the Executive Director of Sepsis Alliance and very concerned about the misdiagnoses of infections and its impact on society, medical costs, medical resources, and the families and patients affected directly. I want to thank SIDM and the Coalition for doing this work. It's really important that we attach numbers to these happenings and so that we can right the wrong that is the disproportionate amount of funding that's happening in this arena. Sepsis Alliance is the nation's leading and largest patient advocacy and education organization. We work nationally. We were founded, as many of these organizations are, by an oral surgeon in Florida who'd never heard the word sepsis before, been practicing dentistry 25 years, never heard the word in dental school, never heard the word in practice, never heard the word in continuing education. It wasn't until sepsis took his 23-year-old daughter, Erin, that he heard the word. Erin went in for what should have been a routine outpatient surgery, unfortunately an oxymoron in this case, and she was perfectly healthy, 23-year-old college student, was going to be a teacher, and Erin went into the hospital and was discharged. Consider the meaning of that word, discharged from the hospital, assuming the surgery had gone completely well. Erin's condition got worse, not better, and they tried to take her back to the hospital once. No, she's fine, normal range of pain. Brought her back a second time, we think she's septic. Erin died 2 days later of what had turned out to be a hospital-acquired infection. This led Dr. Flatley on a mission to make sure no other family would suffer this kind of agony and tragedy if he could do anything about it. At that time, I met Dr. Flatley. If you type sepsis into your computer, spell check would kick it out. Did not exist as a word. Did not exist on the CDC website. Did not exist anywhere. No one was paying attention to this. Yet we knew it was the number 3 cause of death in the country after heart disease and cancer. It is now the number 1 cost of hospitalization, $27 billion a year. Number 1 cause of hospital death. Number 1 cause of readmission to the hospital. It kills more Americans each year than breast cancer, prostate cancer, and opioid addiction combined. Twice as common as stroke, twice as deadly as stroke, but not being addressed at anywhere near those levels. So so what is sepsis? It's often misdescribed as an infection. It's not an infection. It is your body's reaction to an infection. Can't happen without an infection, but it starts off with any kind of infection. It could be bacterial, viral, fungal, or parasitic. Any of those infections can cause your body's inflammatory response, which is sepsis, which starts to shut your organs down and can cause tissue damage, organ failure, amputations, and death. A majority of cases start in the community, so to the point that this is a continuum of care opportunity. First responders, home health care aides, urgent care, on through to the ED, floor, and ICU. There are opportunities that are being missed right now to properly diagnose this at the right time and treat it in the right way. So it also has many after effects. Those who are lucky to survive, so 1.7 million cases a year of sepsis, that's 1 every 20 seconds, 270,000 deaths, so you have about a 15 or 16% mortality rate, very, very high. And of those who survive, about half have significant ongoing either physical, cognitive, or mental challenges. Executive functioning, depression, 42% increased likelihood of suicide among those who have been treated in the ICU for an infection, and 14,000 amputations a year attributed to sepsis. That's 38 amputations each and every day. So these numbers can be daunting and kind of, you glaze over the numbers, but it really comes down to personal stories, like we just heard. 1 in 3 of us will get sepsis in our lifetimes. So think about this, a room of about 60, about 20 of us will get sepsis in our lifetimes. 1 in 15 of us will actually perish, probably before our time. We have a lot of opportunity here to change those denominators. So, when I was preparing a personal story to bring to you today, the challenge was not to find one, the challenge was which one to share. We have over 1,200 personal stories on our website, sepsis.org. Faces of sepsis, people who have survived and are facing ongoing challenges, those who have lost a loved one to sepsis. We have a video called Sepsis in Children, which is an educational video to train parents, families, and healthcare providers. We tell the story of Michael Stolzenberg. Michael was an average 8-year-old boy living in Florida, just having a great summer. He got a mosquito bite, and like 8-year-old boys are apt to do, he scratched the heck out of a mosquito bite, which opened it up. No one knew this except him. He went out to play football with his friends in the dirt and the mud. Suddenly wasn't feeling so well a couple days later. Parents took him to the pediatrician. No, it's probably a virus. It's going around. Not to worry, he'll feel better in 24 to 48 hours. He did not. He got much worse. Parents took him back to the pediatrician, who then did a full body exam, suddenly got suspicious, saw the laceration that was now infected, sent Michael right to the emergency department, where they did save his life. We meet Michael in the video. He's age 17, heading off to college. He's a quadruple amputee. He's doing okay. He's got a new normal. He's stoic. But he says, if only we had gotten to the hospital sooner, I may have been able to keep my arms and legs. And to put it into context, we then go to his dad for an interview, and his dad said if we hadn't gotten Michael to the hospital as quickly as we had, he wouldn't be here at all. So here we have a pediatrician, well-meaning pediatrician, who just wasn't on top of it. It was not on his radar. Almost 2 million cases a year, it has to be top of your consideration set. We're hearing this way too often. And we do believe it's a shared responsibility. This is like stroke or heart attack. This is a medical emergency. You need to know the symptoms. Our new mnemonic, time, like fast for stroke. T is for temperature, high or low. I is for signs of an infection, urinary tract infections particularly, mental status change, or extreme pain or discomfort. That becomes a medical emergency, and you need to get to care. But what happens next is the care ready for you? Is that first responder trained? Is that nurse trained? Is that doctor in the ED trained? And largely the answer is no. So that's where the ball is dropping now, and we have a huge opportunity by educating the public to seek care more quickly, educating and training our healthcare providers. We did a survey of nurses recently, and about 40% said there's no sepsis protocol in their facility, and they don't feel really ready to address sepsis if it comes into their facility. We did one with first responders. Only half of first responders feel that they are sepsis ready, that they have a high degree of confidence in their ability to identify sepsis in the field. Particularly important because half of sepsis cases travel in an ambulance. So we are missing opportunities, low-hanging fruit here, to really make a significant change. So, with that, I will reiterate the call. We need to do more research. When you look at NIH funding around sepsis, it's pennies on the dollar for many other less common and less deadly diseases. We have a huge opportunity nationally to save as much as 80% of the 270,000 lives that we're losing every year. And, think about it. That life is not abstract. It's 1 in 3, it's 1 in 15. It could be us, it could be a loved one. So we have the opportunity to do something about this now. It's low-hanging fruit, and the case is clear, made more clear now with this research, that we can and we should do something about it straight away. Thank you.
Thank you, Tom. I'm startled by that 1 in 3 number that everyone, and yet I think personally, when I was 27 in the hospital for Crohn's disease, my family in the middle of the night was called to say he's not going to survive the night. I was septic, and I did survive. But 55 years later, my dad was in the hospital for the flu the day he was admitted, and I called that evening and say, do I need to rush down there? And they said, he's fine. Come in the morning. Within the hour, he was dead, septic. So, yes, Tom, it happens too often, and it's a failure to consider, failure to diagnose. Dianna spoke earlier of her experience as a patient and how it influences her practice and interactions with her own patients during the diagnostic process. I'd like to invite Dr. Helen Burston, Executive Vice President and CEO of the Council of Medical Specialty Societies, to expand on the support needed by physicians to help improve the diagnostic process. Helen?
Apparently I'm much shorter than our other panelists today. Pleasure to be here with you today. Thank you, Paul, for the invitation, and I'm really pleased to really have this opportunity to talk about this important research today. As somebody who's devoted most of my career to patient safety and quality, between David's new research, Dianna's powerful stories, it begins to make a case for why diagnosis matters. And it brings more focus and attention where it's needed on the seriousness of this issue. And even though it's a serious issue, we also need to acknowledge the complexity of this issue. And I think this is not the time necessarily for a doctor or other clinician blaming. This is a complex process, and we need to put the right resources in front of folks to make this work better. Also important to remember, diagnosis isn't an endpoint. There are so many potential diagnoses, so many potential lab tests. Symptoms have multiple explanations. Getting to an accurate diagnosis quickly can be very, very challenging. You need to act quickly. You can seek counsel from friends or other experts. It requires resources and the time to think about what's most likely, but also not to forget sometimes what you might not normally consider. And it's remarkable that all of us have a personal story to tell. My father was in his early 80s, was having difficulty urinating, saw his doctor, who assumed it was his prostate, because that's what guys in their early 80s have, and just proceeded to go down that pathway of diagnosis and treatment of an enlarged prostate, and completely missed the fact that he had bladder cancer. That was diagnosed once it was metastatic, and he passed away very quickly. So again, all of us have those stories, which tells us this is a systems issue. This is something where a single act by a heroic clinician isn't going to fix what is truly a systemic issue. There's no doubt that physicians and other clinicians really play an important role in diagnosis. It's what we do, it's what we all learn and train to do. But improving the diagnostic process, accuracy, and timeliness takes a team. We need to have institutions, processes, and all working together. From all the way from when the patient shares their symptoms, providing their medical history, being able to formulate the likely explanations for what they have, order tests, report those tests back to the patient, and then the healthcare systems who help us monitor and share all that information. There are too many opportunities across every one of those steps when batons aren't given to the next entity in a true systemic way. So what do we need to do? We need to recognize the complexity of our delivery systems. We need to think about how we can collectively approach diagnostic errors and make them not happen. We need to support clinicians through better access to computer-based decision support tools, and you heard some of this from David earlier. We need to enhance the kind of diagnostic training and education that we provide to physicians and all clinicians. This, again, isn't just a physician issue at all. We need to think about how we use simulation, how we really improve clinical teamwork in a way that gives patients what they need when they want it. Several of my former colleagues from AHRQ are here, and our former leader, John Eisenberg, who is a hero to many of us, used to love to say that patient safety is a team sport, and the patient is a valued member of that team. And really, I think from every story we've heard here, the ability for a patient to advocate for themselves, to be an active member of that team, is really critically important. So we need to think about how we provide the right tools at the right time into the hands of those who need it, patients, clinicians, all, to be able to get a timely diagnosis at the right time. And from my perspective, our specialty societies play a very important role here. Our council is an organization of 44 specialty societies representing more than 800,000 individual physician members. We've committed to working across our specialties to improve care. And without a doubt, this issue of diagnosis is a critical piece for us all to focus on, looking at how we can identify collaborative opportunities to address timely and accurate diagnosis. And even though these are specialty by specialty, the reality for most patients is their care crosses clinicians, crosses settings of care. Again, coming back to this concept of a system. We need to work collectively to create more of that seamless matrix of both the evaluation, the diagnosis, and the treatment for patients. Many of our members already focus on the big three, for example. The American College of Emergency Physicians has been doing a lot of work, for example, on early identification of sepsis. American College of Physicians shares difficult diagnostic cases online. These are all opportunities for shared learning, and again, thinking about how we provide the systems that support an accurate and timely diagnosis. And lastly, in addition to the critical piece around desperately needing the resources to have more research that builds on what we know, we also need to have the ability to track, measure, and improve the diagnostic process. Many of our specialty societies have clinical registries and can really commit to looking at how those registries can really help to support the diagnostic process. So with that, thanks to the Society of Improved Diagnosis in Medicine, David, for your extraordinary research in these stories, really for providing a laser-like focus on the diagnostic process at this critical juncture. Thank you.
Thank you. So we're going to have a chance to open it up for questions from you. I think before we do, maybe I'll have one starter question for everyone. So research is critical, we've heard that, and that's going to take time, though, both to increase the funding and then to get the results. So I'd like each of you to just maybe in 1 or 2 sentences, what's the one thing you think we as individuals or we as a health system can do now to start to improve the problem of misdiagnosis? Dianna, I'll put you on the spot by asking you first.
I feel like I need a moment to think about this one here, but the thing that automatically jumps to my mind is trying to improve communication between physicians and other healthcare providers and patients. I'm obviously thinking of my own story first, since that's the one that's the most personal to me, but I keep thinking about how some of our issues with delayed diagnosis might be due to the fact that patients' complaints or concerns are kind of downplayed, or they're reassured when they shouldn't be. So I think that if there was some way that we could kind of improve the communication so that patients are feeling heard and understood, and physicians are also being able to hear and understand their patients and not necessarily minimize those concerns, that could be a step.
Great, thank you very much. So clearly, every patient has a story. That's actually a book by Lisa Sanders, and it says the inside those narratives are the key clues physicians need. David?
Obviously, that's a tough question. You could point to any number of things: teamwork, training, technology, measures, feedback, tuning. But I think if we were going to make the most progress the fastest, it would be to change our access to the providers that are most well equipped to address diagnosis for a given clinical condition. We know that at the end of the day, most diagnostic errors happen at the bedside in the patient, basically in the clinician-patient interaction phase of the encounter. And although eventually we expect there to be substantial amounts of computer-based diagnostic decision support, and we expect to have changed our educational systems to be able to enhance people's diagnostic skills and training, I think that being able to phone a friend is really the critical piece of the story if we're going to fix diagnosis tomorrow. There is almost always somebody who knows the answer, and it's just a question of getting to that person. One of the things we've done at Johns Hopkins is we've made that access possible. So in focusing around stroke misdiagnosis in the emergency department, we've essentially added a lifeline call to phone a friend, a specialist, if you have a patient who comes in with dizziness. We know that dizziness is the symptom where we missed stroke the most. So we just said, look, if you have a dizzy patient where you don't know if it's a stroke, just call us. We'll help you. And we provide a teleconsultation service immediately to them. And I think that's probably the mechanism whereby we could do the most good the most quickly in the very short term.
Thank you. Tom?
Thank you. Yeah, sepsis is tricky because it presents in so many different venues, in so many different ways, and when it's easy to treat, it's harder to diagnose. There's no simple test for it. There's no simple cure, so it really relies on clinical acumen. But as a nurse told me in Uganda once, even a blind man can see sepsis. So I think that's a word to us who are so dependent on technology. It really is a clinical suspicion of sepsis, and I think we need to integrate that thinking. It's hiding in plain sight. It is extremely common, and we need to develop a kind of a overall awareness of that fact, that this is right in front of us, and we need to have greater consciousness of this as patients, as families, as healthcare providers, and then that the providers have a mechanism in place. And those hospitals and healthcare systems that have done this have seen reductions in mortality by 50% or more, simply with putting kind of a process in place for screening in the emergency department and then kind of a tracking through their system. This is without any new invention or billion-dollar research. This is simply kind of engineering, process engineering. So I think SEP 1, CMS measure, is very helpful if needing some work, but it is drawing our attention to kind of a process improvement that's required around the identification, recognition, diagnosis, and treatment of sepsis.
Thank you. And Helen?
Always hard to go last after all the good suggestions. I think the one thing I would add, I agree completely. I think recognition is key. We have a problem, and I think this has been an issue we've not talked enough about in healthcare and in medicine. I think simply having a forum like this, having the research findings from David and many others now allow us to recognize it. And I would also add, perhaps not surprisingly given my own background, that I think we need to track it, measure it, understand it, learn from those misdiagnoses. And I think as long as we don't do that, we cannot make the significant progress that we need to as a nation.
Thank you very much. Okay, questions from the audience, and we'll bring a microphone to you. No need to stand up or anything. Yes, first question's over there. Please just say your name and where you're from.
Yes, hi, my name is Bailey. I'm from Oklahoma. I appreciate the topic of this conversation. It hits me very personally. I lost an aunt about 6 months ago to sepsis, and so this conversation hits home for me. One thing I didn't hear discussed in the dialogue is the presence of implicit bias in the health profession, because while this is a systems epidemic, it especially hits Black women at a higher rate because women of color are often not taken seriously or dismissed. I had my sister recently was ill with her blood sugar, and her primary care doctor ignored it, but she took my niece to the pediatrician, and the pediatrician noticed my sister's energy and behavior different, was able to spot it, get my sister to the ICU, get her emergency care. That probably would have saved her life. And so I'm just curious to know if the coalition is focused on that level of implicit bias, or what can be done in the medical profession to ensure that women of color aren't getting ignored.
So thank you for that question. Let me just respond from a society perspective that we are currently conducting research that's funded research in partnership with Stanford around the issue of disparities. But in the research that was done today, or in other research you're familiar with, maybe David, can you speak to the issue of disparities?
Sure. Obviously, healthcare disparities are a major issue, and patient safety and diagnostic errors are no exception. Not in this particular study, but in one that we published a few years ago. We looked at this issue when we were looking at stroke misdiagnosis in a large national database using the Healthcare Cost and Utilization Project data. And what we found is exactly what you suggested, which is that minorities and women are 20 to 30% more likely to be misdiagnosed than their male white counterparts. And there's no question that that's true. It's probably systemic, and it's not just a stroke-specific thing, it's probably across every kind of diagnostic error. I will say that there are also other demographic disparities that, for instance, we saw with the stroke cases that young people were particularly at higher risk. And it's often the case, as with Diana's story, that a young person is not expected to be sick, so when they have a disease that sort of doesn't fit their demographic group, they're that much more likely to be misdiagnosed. So you were probably in the highest risk demographic group, you know, an African-American woman who was younger, and having a disease that, you know, was thought of as a disease of the elderly. So I think this is a critically important issue, and one that we have to tackle as we go forward in this area.
Anyone else need to make a response, or we'll move to the next question? Okay, another question over here, and then we'll come back to Joyce.
Excuse me. I'm wondering if your coalition includes allied health professionals, because I can tell you that as an occupational therapist, I would spend 2 hours a day with my patients, and I would see behavior that I knew something was wrong, and I would call the doctor, who would come in the room and spend 5 minutes, and the doctor would say, oh, nothing's wrong. And I'd say, but I spent 2 hours with this person. Something's wrong. So I'm wondering if occupational therapy, physical therapy, if some of these others are part of your coalition.
Thanks for the question. We've had one, I think, that I can remember, physical therapist who's come to multiple ones of our conference. There's certainly no reason why the professional organizations that represent those specialties couldn't be a member of the coalition. They are certainly welcome. They have not joined yet. Maybe you can help encourage them to join. We'd be glad to help you in that endeavor. Another question, Joyce? David?
Yeah, could I just also say, this is a critically important issue. The #1 National Academy of Medicine report recommendation was to make patients, families, and allied health professionals part of the diagnostic team. If you look, there are a couple of really good papers on diagnosis as a team sport, one that we published and one that was led by Mark Graber on the new diagnostic team. And if you send me an email, I'm happy to send you the paper. But we engaged a physical therapist around this issue. I think it's a critically important problem, and I think the entire team has a lot to offer.
Yeah, and I would share, we just started working with the American Physical Therapy Association, and I agree there's a huge opportunity there. In one small trial we did in upstate New York, every physical therapist who goes on a home visit is doing a sepsis screen. It takes about 3 minutes. In just 6 months, they uncovered 250 sepsis cases. That's a physical therapist coming into a home care environment in a small region of New York. And if you nationalize that number, the impact is tremendous. So it's about empowerment of these all healthcare professionals to be on the lookout. And we see the numbers that are just, really inspiring.
Thank you. Joyce, you had a question? Please identify yourself for the record. Yeah.
Sure. Joyce Frieden, MedPage Today. I wonder if you could talk about the role that stigma plays in terms of doctors not wanting to admit that they misdiagnosed somebody, and kind of how to move the ball forward on getting more discussion.
Helen, can we start with you? You represent so many physician specialties.
I think it's a really important question, Joyce. I think all of us can immediately, any clinician you talk to will immediately think of a patient they saw where there was clearly an issue. All of us know that. I think part of it is, I think there is some stigma, but I would argue, I think some of it is we often don't even know what the ultimate diagnosis was. We may see somebody at some point along their journey, and that's why I think, again, really being able to look at care across a seamless matrix. What do we really know about what happened to a patient at a different point in time? Feeding that information back to clinicians is such a powerful learning tool, but we often don't even know. You may hand off to the next place. Somebody may have had surgery and then go back home to their small town. Does the person who did the surgery even know what happened 2 or 3 months later? Again, those opportunities for better systems, better understanding, better information systems, and better outcome tracking so we can learn from those events, I think is really critical.
Yeah, we've suggested that the absence of feedback loops is one of the problems that prevent physicians from calibrating themselves, from learning from their experience, because they aren't given feedback on what happens. And so agree with that totally. Yes, sir.
Hi, Ryan from the Centers for Disease Control and Prevention. I was wondering what the role of telemedicine and data modernization would play in the reduction of sepsis or even catching it more. What will your perspective be on that?
Tom, do you have any information, or David, who wants to take it?
So in terms of telemedicine, there are lots of good examples of how that's being used effectively, bringing a greater degree of knowledge and expertise to bear on a patient. And I think there's tremendous opportunity there, particularly in rural areas and underserved areas. It can also be a partial way, at least, to respond to kind of underserved populations and those who are doing less well if they don't have direct access to care. So I think it's we've seen some good examples of it, and I hope it continues to grow.
I think in terms of effective data usage, I'm a big fan, a believer, as I mentioned earlier, of accessing the sort of phone a friend mechanism. I think in terms of data usage, I think we just need to be much more effective in the way we're using the clinical data that are available to us. At Johns Hopkins, Suchi Saria and others around the country are working on, for instance, artificial intelligence-based algorithms to, machine learning-based algorithms that allow us to identify patients who are becoming septic sooner rather than later. I think there are a lot of things that we can do with data visualization to be able to document and identify trends that are not apparent when you're just presented with sort of a raft of different screens and you're not given the sort of information on how things are going. So I think there are a lot of things that we could do in that domain space that would help us improve diagnosis of sepsis and other things as well.
Just a brief comment to extend on that. I think we often think about telehealth in this time of being direct to patients. There's a huge part of the diagnostic process, which is also about clinician to clinician, sort of the technology behind phone a friend. In many ways, the ability to access the most qualified person when you need them in real time is part of what clinician to clinician telemedicine really provides. There's some great examples of that. Actually, when I was at AHRQ, for example, we funded Project Echo, this remarkable opportunity to be able to access experts when you need them to help you through a process. That's more about treatment. It could just as easily be about diagnosis as well.
And the only thing I'll add to that before moving to the next question is that telehealth is one word which means a lot of things, and there are always upsides and downsides and unintended consequences. And so while you're at one point increasing access, at the same point you're removing potentially the fingers, the eyes, the ability to collect data. So it's certainly a balancing act, but there's so much potential with it. We have another question. Yep.
Oh, thanks. Hi, my name is Claudia Simone. I'm with Simone Consulting Group. I'm actually a consultant in healthcare and higher ed. and a patient advocate because both my brother went through sepsis 3 times. The third time I diagnosed him and told the hospital what was wrong, which is crazy. Second one, my sister was feeling bad, dizzy, went into an urgent care, was told she had severe anemia. 2 months later was diagnosed with gastric cancer, metastasis to the liver, and she ended up passing 3 months later. So I'm, a huge proponent for the advocacy of this. But my question is, I think it goes beyond the healthcare. Are any of the societies talking to, like, let's say, the AAMC, AMA for medical education, for medical schools, where this should be an issue that's pushed so the physician of tomorrow can actually, look at a patient and say, I think that's what's wrong with this patient?
So certainly the Society to Improve Diagnosis in Medicine has received funding from the Josiah Macy Jr. Foundation to work with other organizations to develop an interprofessional consensus curriculum. In many medical schools, they don't address uncertainty, they don't address biases and things like that. They teach illness scripts. And so we believe that that curriculum needs additional components to help physicians think about cognitive biases and to think about the uncertainty that's built inherent in the diagnostic process in new ways. Did anyone else want to add anything?
Say certainly AAMC, ACGME that does residency programs have all really focused on the key competencies here around diagnosis. A lot of medical schools in particular, for example, have moved to case-based learning, where it's not about here's a person who had a stroke, but here's a person who comes in with symptoms. And that case-based approach can really be powerful. I'm sure David could say more.
Yeah, well, I'd just like to follow up on that around the issue of simulation in medical education. So ultimately, this boils down to experience and feedback. And what we've shown is that it's basically impossible to, it takes more than 10 years to get to be an expert diagnostician if you just rely on your clinical experience. And that's if you're getting feedback. And if you're not getting feedback, you go a lifetime and it never improves. So what we've been trying to do is bottle the experience in virtual patient encounters. So we've taken our clinical trials data around the diagnosis of stroke in dizzy patients, put them into virtual patient simulators, and just recently we did a pilot study that will be hopefully coming out in November, but I'll give you the headline, which is that in 9 hours we trained medical interns to be better at diagnosing stroke in dizzy patients than the medical seniors that were graduating.
Thank you. We have time for one more question.
Hi, Adele McClenny, and here we are on Capitol Hill, and I'm just wondering, what can Congress do to make a difference on this issue?
Well, certainly Congress can fund research. As David pointed out earlier, we are spending less on research in this area than an eradicated disease like smallpox, and yet we're talking about something that is minimally $100 billion a year, not even counting the lives that are destroyed or damaged through this process. So research is certainly one, but it goes beyond just research funding. It goes into the electronic medical record. Diagnosis isn't about diseases, it's about symptoms. And we don't have ways to track that. We're building these huge clinical data sets that in many cases are missing the data that a physician uses, the social determinants, the disparity information, the symptoms and the course of the symptoms. And just the interagency task force that AHRQ is leading will be an important thing that we have to make sure is appropriately funded to continue the discussion so that we have alignment. There's too much to do and too few people doing it, so we need that. David or anyone else, would you like to add any comments?
I really think, just sort of speaking from the Hopkins experience, where we were very fortunate to have a philanthropically endowed Center for Diagnostic Excellence, that we should capitalize on those kind of models. We really need to build capacity in the field. And right now, there are just too few individuals that are doing work in this space, both at the research level and at the operational patient safety level. We need to find aggregations of people. We need to learn from each other. And I think one of the best models for doing that is the notion of centers of diagnostic excellence, which might be populated around the United States and serve as kind of hubs for training, for research, and for operational improvement to reduce diagnostic errors and improve diagnostic outcomes. So I think that's a critical issue that the federal government could help with.
Any other comments before we close?
I'll just make one other point. I think beyond the research, and I think the centers of excellence are critical, there are huge opportunities, I think, as well, as a large payer of healthcare as well, to think about how accurate and timely diagnosis gets factored in to some of those considerations around value-based payment as well.
Okay, it's nearly time to conclude. Please join me in thanking all of today's speakers, Dianna, David, Tom, and Helen. I'd also like to extend our appreciation for the grant that made both the research and today's gathering possible. Thank you to the Gordon and Betty Moore Foundation and the Mont Fund. And I'd be remiss if I didn't thank all of you for joining us today, including those who followed us along online. For those of you who represent healthcare organizations, I'd like to encourage you to consider a donation to SIDM and to consider joining our coalition. More information about SIDM is available at improveddiagnosis.org, while information about the ACT initiative is available at betterdiagnosis.org, and you can get to either from both. And in closing, I'd like to encourage you to consider joining us at this fall's Diagnostic Error in Medicine's 12th Annual International Conference. It's going to be held right here in DC on November 10 through 13. As with today's research, more information about the conference is available at improveddiagnosis.org. Thank you again for joining us.